Maybe we'll get started. I'm sure we'll have some more people join us. My name's Casey La Rochelle. I'm with Strategic Partnerships of FNHA, and I'm located in Nanaimo territory where I grew up in Nanaimo, though I'm from the Haisla Nation. So welcome all to the Indigenous information session on communicable disease emergency planning and supports. We're recording it and we'll offer the link to people to share, and any presentations that are given to us and materials we'll share after as well. And I'd like to start, I'll call upon people for introductions. So if you're able to share your position in the community, anything you'd like to learn about communicable disease planning, emergency planning, and basically any expectations you have of the session today. So I will start with Shiro Nand.
Good afternoon, everybody. I am Shiro Nand, the CDE Nurse Advisor for the provincial team. My expectation for this session is for me not to stutter.
That's a good one. Stephen Stavanis.
Well, you just said it, Casey. I'm the community manager here at Nanaimo's First Nation in wonderful Ladysmith. And I'm looking forward to just making connection with people that I've seen on email chains, and hopefully getting a good plan with our health director, Allison, about how we go forward addressing these kinds of emergencies. So thank you.
Good to meet you virtually. I see Don. D-O-N.
Yeah, hi. I'm Don Gillespie. I'm Public Works and Housing and Emergency Operations Coordinator for Untitled First Nation. Basically trying to keep my head above water in regards to what's going on. It's it feels like I'm rather routinely 2 or 3 steps behind the curve. So I'm just trying to keep up. So
good to have you taking the time today. Daniel Chan.
Apologies, trying to find the button here. My name is Daniel Chan. I'm calling in from the traditional territories of the Casey and Salmon Nations here in Surrey Newton area. I am the team lead for the Communicable Disease Emergency and Infection Prevention Consultation Services team. I think it might have been the longest name in FNHA, but I used to stutter through that, but it got better over time. But I'm really grateful to be here. Please pardon my stuffiness. I'm still trying to get over a cold, and so I guess one of the expectations I have is hopefully things don't come out my nose while I'm talking.
Thank you for making the time. Veronica Refuse. Sorry if I got that wrong.
That's okay. It's pretty close. Refuse. So I am Health and Safety Officer at Seabird Island Band.
Good to have you. Brendan Reeve.
Hi there. I'm joining from Seabird Island as well. I'm the proposal writer, and I was hoping to learn a bit more about the ongoing operations and opportunities, and maybe anything related to funding that might be relevant.
Good to have you. I put my email in the chat, and I don't know if you get our monthly emergency management funding list, but if you don't, send me an email and I'll make sure you get it. Chris Marsh. Good to see you, Chris.
Yeah, good afternoon, everyone. Hello from Begbie Summit here on Highway 97. I'm an emergency management advisor for the Tanaka Nation Council, and just looking forward to have an update on where things are at after a long wildfire season. Good to put our minds back to human-based hazards as well. So thank you.
Thank you. Brittany Dieter.
Hello, everybody. My name is Brittany Dieter. I am the Director of Communicable Disease, Population, and Public Health here at the First Nations Health Authority. I'm joining you today from sunny Semiahmoo territory in the Lower Mainland, and I'm here to support Daniel and Shiro.
Thank you very much. And you're really faint, but if you're not presenting, I'm assuming it'll be good. I was able to hear you, but it was noticeably faint.
Let me
Michelle.
Thanks.
Michelle Jacobs.
Good afternoon, Michelle Jacobs. I work for the decision support team as the technical trainer for FNS. I am just listening in to learn some things.
Thank you. Dakota.
Morning, everybody. My name is Dakota Castonge. I am the Community Support Assistant with the Emergency Planning Secretariat. This is my second week on the job, so I'm just excited to get some more information to help me be more successful in my role.
Thank you, and good to see your organization here. The one and only Allison Lohman.
Hello, I'm with FNHA. I don't know if you can see me because I'm too much sunshine here. I am with FNHA with the Preparedness Department and working mostly on emergency planning, and always love these opportunities to listen and learn from communities.
Thank you, Allison. Aislinn Gentles.
Hi everyone, my name is Aislinn Gentles. I'm with Soto First Nations up here on the east end of Moberly Lake in northeastern BC. I am the Occupational Health and Safety Coordinator / Emergency Management Program Coordinator. I am also just getting over a cold, so I can appreciate that sentiment. And I'm just looking forward to hearing, where we're at and what we can kind of do in the next year to start thinking about communicable disease again. Thank you.
Thank you. Stephanie Louie.
Hi there, Stephanie Louie. I'm the Lands and Natural Resources Officer for Keithkit. Yeah, thanks.
Good to see you here. Shadley Taylor. We can circle back if you're multitasking. We'll circle back. Renee Williams.
Hi everyone, Renee here, community health nurse at the Kwagil First Nation, and just looking to revisit our CD plan and go over any relevant resources. Thank you.
Thank you. Jassy, sorry.
Hi, it is JC. I'm the Emergency Management Assistant for Soto First Nations. I work under Aislinn Gentles. My background is primarily in wildfires, so I'm just interested in getting a baseline understanding of pandemic planning.
Thank you very much. Chris Ross.
Morning, my name is Chris Ross. I am the training exercise specialist for the provincial HEM team for First Nations Health Authority. I'm calling you today from the territory of the Squamish, Musqueam, and Tsleil-Waututh people out in North Vancouver.
Thank you. Joseph Eligi, and sorry, your last name's hyphenated, but it's only partially there.
It's Joseph Eligi-Biro. Hi, everyone. I'm the new Deputy Fire Chief of the Yakitat-Nucleat Tobacco Plains Fire Department, and I'm just sitting in to get as much information about how things work around here as I can. Looking forward to it.
Thank you very much. Daryl Adrian.
Hey, Casey, thanks for today. Daryl Adrian at the Lulua Tribal Council Emergency Management Coordinator. Thank you.
Thank you, Daryl, and thank you for presenting yesterday. It was a very good workshop. Rose Jack.
Rose Jack here, Mochit First Nations Community Health and Family Services Manager. And Zaina invited me to attend. She's busy with another workshop.
Good to see your nation here. Terry Kish.
Hi, I'm Terry Kish. I'm the Old Masset Emergency Services Department Manager, and I'm here to see, like you said, about communicable diseases and just have that conversation about maybe having some type of a debrief on what we've already been through in the last 3 years so that we can make things better.
Thank you. Moving back, Shadley Taylor, if you're able to introduce yourself.
I hope so. Can you hear me?
We can.
Okay, awesome. I was madly clicking away earlier, but you moved on. I'm sadly Taylor, obviously technically challenged health director from Pachudat First Nation, and I'm here backing up our newly hired emergency coordinator, Mark, who's not here today. So I'm learning all I can from you guys.
Thank you very much. And before we move to the main presentation, in the email of the calendar invite or the message of the calendar invite, I put in some links there for things like the WorkSafe BC COVID data for employers. I put in a BC Center for Disease Control information on COVID testing and testing and treatments. And then also in the chat, there's the COVID self-assessment. And I'm not sure if organizations are still using that. I know at FNS, we talked about that just this morning, that it's probably still a good tool for us to use if we're considering going into our work with our team or going to in-person meetings. It doesn't hurt to do the self-assessment and make sure that, we don't have symptoms that would merit perhaps getting a COVID test, or even just staying at home until the symptoms go. So with that, the main presentation is Communicable Disease Emergency Planning for Communities. And I will let First Nations Health Authority take over.
Thank you, Casey. I will go ahead and share my screen.
Perfect.
Thank you. Okay, so good afternoon, and thank you for the opportunity to share our communicable disease emergency response and planning resources and supports. Myself and Daniel will be your presenters today. And as I mentioned earlier, my name is Shiro Nand, and I have been the Communicable Disease Emergency Nurse Advisor on the provincial team since May of 2020. And Daniel Chan introduced himself earlier, and he will be speaking later on. I would like to humbly acknowledge the traditional and unceded territories of the Squamish, Musqueam, and Tsleil-Waututh people on which I am presenting from today. Today, we will cover how the First Nations Health Authority, or FNHA, supports have evolved over time, learn about the supports and tools we offer, and learn how to contact FNHA for support with communicable disease emergency planning activities. Communicable diseases are caused by microorganisms such as bacteria, viruses, parasites, and fungi that can spread directly or indirectly from one person to another. These microorganisms have been detrimental to us in the past and pose serious risk in the future. This slide tells us the approximate number of microorganisms in the world. There are approximately 5 million trillion bacteria, 10 nonillion virus, which is 10 to the 31st power, 75 to 300,000 parasite, and 6 million fungi. Not all of these microorganisms will go on to cause disease in the population, but considering the sheer number out there, we know to be prepared to respond in the future, because communicable diseases become an emergency when the number of communicable disease cases exceeds the current capacity of their primary response program. I will be using the acronym CD for communicable disease and CDE for communicable disease emergency for the duration of the presentation. I will pass it over to Daniel to talk about CDE response planning supports prior to COVID-19.
Thank you so much, Cheryl. Just to describe CDE planning, as I know there's a lot of questions about CDE planning, where it came from, where it stemmed from, and where are we at with CDE today. Just to give a little brief description and a little history. and explanation, CDE is really part of a broader framework of a all hazards plan, with a distinction lying in its health focused nature. Unlike natural disasters like fire, floods, earthquakes, which we kind of almost can say these are direct disasters or natural disasters, CDE involves diseases that necessitate expertise in communicable diseases. And this is a specialization in healthcare when it comes to communicable disease control. However, this does not mean that healthcare experts are solely responsible for writing or organizing a CDE plan document. The forming of the plan, which Cheryl will go into more detail later on in this presentation, involves input from all sectors, from all people. As we have in this group, there's a variety of people from different disciplines, and this is just a crumb of the necessary people that are needed to be involved, to partner together, to collaborate together, to create this unifying CDE plan for a community. And so consolidating the plan into a document, really, again, consolidating a plan doesn't really need the specialization of healthcare practitioners, et cetera. But these individuals do need to ensure that they are aware of those who are consolidating it. They need to be aware of who to contact to add those individual expertise, fire, police, health sector, et cetera, public works. They need to add those expertise and put it all together into this plan. And in other words, it's actually really connecting people together. And I used to say a very good prerequisite for the role of somebody consolidating this plan is someone with very neat writing, or at least someone who can read their own writing, unlike myself. But with today's computers, it's not really an issue anymore. Therefore, the changes used to be highly supported by the provincial team. When I started, it was just me supporting, being a resource for 203 communities. And then we did expand, and then Cheryl and a colleague also became part of the team as well. So we expanded to a team of 3. And then with the pandemic that occurred, it expanded into the supports extended to regional roles to support each region at the forefront and on the ground to help with each community's CDE planning. And that's where we are today with the evolution of the resources that is provided for CDE planning. And I will let Cheryl continue on with discussing CDE and its particulars.
Thank you, Daniel. So I actually started in my role during the height of the pandemic. And during that time, the focus was supporting communities in BC with creating their CDE response plan for community level response. It was very challenging to engage in planning activities when everyone was in response mode, but communities collaborated with partners and stakeholders for their best possible response. We'll take a look at some of the resources and supports that we developed during that time later on in the presentation. This year, we are switching gears and focusing on CD response planning for healthcare facilities in First Nation communities, and we will talk more about this also later in the presentation. We offer a variety of supports and tools for CDE response planning. There is a guide and accompanying template for community-level CDE response planning, and some regions have taken these and adapted it to reflect their specific regions. We conduct facilitated scenario-based discussions, and we encourage this during the initial planning phase and planning phases to guide decisions. We offer tabletop exercises, and this is done in collaboration with the regional FNHA teams. The central team, myself and Daniel, are here to support and field any CD response or CDE planning requests and questions. At the request of some communities and in collaboration with the community development team, we have facilitated and participated in sharing circles. And based on those requests during the sharing circles, we covered topics including our supports and resources, scenario-based discussions, and anything else related. When there is opportunity, we collaborate with other FNHA teams to provide a more robust support. And one example of that is the CD readiness assessment, and Daniel will speak on that later as well. Also, based on requests and availability, we offer a customized multi-step approach to CD and CDE response planning. Our tools and supports can actually be found on the CDE webpage on the FNHA website, and you can navigate to this page by visiting the FNHA website at www.fnha.ca. Click on What We Do, then on Communicable Disease Control, and lastly on Communicable Disease Emergency Response. And this is what the page looks like. One of the tools found on our page includes the CDE Response Plan Companion Guide and the accompanying template. These documents were created during the pandemic with real-time experience and wisdom from a variety of people guiding this work. This included various councils, governments, and nations, as well as FNHA team members from various departments. And we're so thankful to have that wisdom. During COVID-19, some communities had outdated or incomplete response plans, ones that focus specifically on influenza or may not have had a response plan at all. The importance of having a plan became quite clear. The purpose of having an up-to-date response plan is to be able to support a coordinated response to a CDE. A good plan should be able to be scaled up or down depending on the needs of the community. The purpose is to protect community members and staff. For new and emerging communicable diseases, we may not know the route of transmission, so a good plan should consider responding to all modes of transmission. And the purpose is to safely maintain essential services that are crucial to preserving life, health, public safety, and basic societal functioning. There are various components to consider when creating a robust CDE response plan. Some of the most important components that are covered in our guide include infection prevention and control, a communication pathway, the priority community members list, and culturally safe practice. Over the next few slides, we will take a closer look at each of these. Infection prevention and control is a crucial part of CD and CDE planning. In the guide, we discuss the hierarchy of controls, including personal protective equipment. Daniel will speak more on this, including CD readiness assessments and infrastructure later on. A communication pathway is one of the most important elements of a strong CDE response plan. Communities have established ways they successfully communicate with community members, and this information is especially important to include in the plan for new or temporary staff or staff that may be covering during the emergency. The guide suggests to create an established communication pathway to community members, regional health authority, and First Nations health authority to send and receive crucial information in a timely way. Another component is creating or updating a priority community members list. While diseases can make anyone sick, some community members will be more at risk of getting an infection and developing severe complications due to their health, age, social, and economic circumstances. This could include individuals such as infants, individuals living with chronic diseases, and ones who are immunocompromised. The priority community members list identifies individuals who are vulnerable or susceptible ahead of time so they can be prioritized for closer monitoring and treatment. This list can actually be utilized during any type of emergency. There is an additional resource that guides how to create the list and what to consider, and this can be found on the CDE webpage. Culturally safe practice is a component woven throughout the guide and embedded in our work at FNHA. Our practice is guided with the core concepts of respectful engagement that recognizes and strives to address power imbalances inherent in the healthcare system. We believe in self-determination, participation in decision-making, respect for and protection of culture, equality, and non-discrimination. One of the ways this has been done is by creating culturally safe messaging in collaboration with elders and knowledge keepers. During the COVID-19 pandemic, cultural activities and supports had been altered to continue in a safe way. Some ideas included in the guide shared with us by communities is virtual language learning, outdoor singing and dancing, and online or outdoor cultural workshops such as harvesting medicine. Elders and knowledge keepers shared traditional healing activities in conjunction with public health recommendations. Several other important components can be seen on this slide. Most of you may be familiar with the Emergency Operations Center, or EOC, but just a quick review, it serves as a critical role in every phase of emergency management, from being the hub for all coordination during an incident to facilitating and directing recovery. An EOC has not commonly been used in public health response to emergencies. It's a fairly newer concept in this world. In the case of CDEs, and the main difference from a traditional EOC structure is decisional input from a health representative. This is vital as CDEs, which Danielle mentioned earlier, are unique and have significant differences from environmental hazards. We discuss how the optimal EOC structure for a CDE will vary based on the community's governance structure. And for a coordinated response, we recommend to include the health director and/or health representative, as well as chief and council as part of the EOC, and to clearly define how the collaboration will occur. Another component is maintaining essential services. In the guide, we go over prioritizing and developing strategies that maintain essential services during an emergency. We suggest being proactive in implementing and maintaining reasonable precautions based on public health guidelines and organizational hazard risk mitigation policies and procedures. Ensuring these supports are in place will enhance the safety and resiliency of essential services staff. We briefly refer to the business continuity plan as well, which can help community leaders identify and maintain critical services during an incident when people and resources may be diverted, and to help reestablish full functions as quickly as possible following an event or an emergency. Another important component is surveillance. Surveillance activities occur at the federal, provincial, regional, and community levels to monitor for emerging patterns and ongoing cases of reportable communicable diseases, with the goal of predicting, observing, and minimizing the harm caused by CD events or emergencies. We focus on encouraging continuing routine surveillance practices, such as reporting reportable communicable diseases. Path to Wellness is another component, which includes both non-traditional and traditional medicines. An integral focus of First Nations healing and wellness is recognizing the balance and interrelationships of the physical, mental, emotional, and spiritual aspects of being. During a CDE, land-based activities and harvesting traditional foods are only a few examples of upholding traditional wellness. First Nations and Indigenous groups have a long history of self-determined perspectives of health and well-being, so leaning into the wisdom of elders and knowledge keepers to guide the traditional ways can help keep communities on the path to wellness during a CDE. We also include a section on recovery. After the emergency is over, the community can work together to recognize the losses, celebrate their resilience, and begin the healing process. Recovery is the phase in which action is taken to reestablish social, cultural, physical, economic, personal, and community well-being through inclusive measures that reduce vulnerability to emergencies while enhancing sustainability and resilience. It includes taking steps to repair the impacted community and restore conditions to a level that could withstand a potential future event or increase resilience in individuals, families, organizations, and communities. This section includes activities such as reviewing the impact of response activities, including after-action reports, recovering costs, resuming ceremonies, programs, and services, debriefing with staff and community members, using lessons learned to guide future planning activities, engaging in community dialogue to support evaluation of the response and future planning, engaging in cultural practices and ceremony to support healing. And also included in this section are questions to reflect on when considering lessons learned. Now, as I mentioned earlier, we are shifting our CD planning gears and focusing on CD response planning for health facilities in First Nation communities. We recognize that communities and health facility staff have different amounts of time to dedicate to CD response planning. So we want to equip them with the important components if they don't have time for anything more. In the future, we will be introducing a webinar series with short videos on how to complete certain sections of the CD response plan. The information can also be applied to the community level planning resources. The series will consist of 4 videos, the first one being an overview of resources and supports, the second one being priority community members list, the third one will be communications pathway, and the fourth one will be modes of transmission with a guest feature from our wonderful IPCS team. In the more distant future, we're hoping to add a webinar series for requested topics and CDE tabletop exercises. CDE planning supports can be found at each region as well. For supports with CDE planning activities in the Northern region, you can connect with the Northern Health Emergency Management Team, and their email is found on the slide. For CDE planning supports from the Interior region, the community practice consultants are available. That is Carol, Catherine, and Shauna, and their emails are also on the slide, which we will share later on at the end of the presentation. For supports with CDE planning activities in the Vancouver coastal region, you can connect with Lana Bickle, who is the acting manager for nursing. And for Fraser Salish region, Natalie Gill is the CDE nurse advisor to support the CDE planning activities. And lastly, in the Vancouver Island region, Ashley Marshall is the CDE nurse advisor who is available to support. For supports with CDE planning activities, you can also connect with us at the provincial team, and our email address is cdmgmt@fnha.ca. And you can send any questions, requests, comments to this email address, and it'll come to myself and Daniel. Now I would like to pass it over to Daniel, who will discuss infection prevention consultation services and briefly about the community development team's supports and contacts.
Thank you, Cheryl. I just want to take this time just to introduce another resource to all of you, which has been kind of mentioned already in the presentation from Cheryl. The IPCS team, which is Infection Prevention Consultation Services team, is it used to be infection prevention and control, but we're like, yeah, no, we're not going down that route, and we don't want that whole control word in there because it's not. It's about partnership, about consultation. It's about coming together and finding strategies together. Cheryl, you mind going to the next slide? So a little bit about our team. The IPCS team consists of 3 of us. There's myself, there's Tess Giuliano, and our third new member is Angela Mitra. And our team basically, well, all of us have quite a bit of experience in infection prevention. Well, we also come from different backgrounds as well. Tess from occupational health and safety, Angeli research and epidemiology. So very variety of backgrounds for myself. Is a lot about operations and strategic planning. So it really just is beautiful. I can't say more enough that how blessed I feel to actually have a team like this. And we're very practical people. We all have been managers ourselves. And so when we give advice, we try not to anger people, basically try to be as practical as possible. What we do is we provide consultation on risk management and mitigation strategies with regards to preventing the spread of infectious diseases. There are many guides and documents out there and policies, best practice, mandates, etc. Anybody can read those, but the tricky part is actually knowing which is applicable and how to apply them in each specific setting. We acknowledge that every community and every setting within community is very, very unique from one another. And so therefore, it is important to be able to come together and find the right strategies that fit for each person, for each setting. And by doing that, we're preventing harm to the clients and staff inside those facilities. We're preventing harm to the community, but we're also minimizing unnecessary waste and resources, because we all know there are limited resources. During the pandemic, with all the fright and all the fear, there's a lot of dumping of resources here, left, right, and center. And then there were programs also that was left unintended. And also because of some of the interpretations of the general mandates and guidance from the province, sometimes it can lead to programs actually stalling or being inactive because of that fear of COVID spreading around from the past pandemic. Such services that we have seen and have talked to some communities about that struggle with keeping some services open were like mental health and substance abuse support programs, some of the cultural safety programs, some of the other health and wellness programs such as maternity, infant, child, and youth programs. A lot of programs had suffered and has stalled, and they were put on pause, during the pandemic, because of that fear. But then we see 2.5 years later, we see the consequences of such services actually being on hold or not being able to be delivered during that time. And we see it with the opioid crisis. We see it with mental health issues and challenges these days. We see a lot of these, and a lot of supports were not there. But did it have to happen that way? And, not entirely. There were many ways which a lot of these services could have continued and operated. It just needed some tweaks and some strategies to be able to keep it safe for people, to be able to interpret the guidance from the province in a way that, yes, you do meet it, but you can still deliver these services. Yes, there can still be that meeting. There can still be interactions, but in a safer way, And there was ways of doing that. And so this is what we provide, is that strategic kind of thing, that collaboration of how to kind of interpret and is the how, not just the what, how to apply different strategies to make things work. And I'll get you to go to the next slide, Cheryl. Thank you. So there was a question, not a question actually, when we're going around the table about the expectations or the challenges that people face. I remember, Don, you mentioned that sometimes we feel like we're a little bit behind or 2 steps behind, or always chasing when there is this communicable disease event that actually happens. And yes, it can. Actually, a lot of times it did feel like it during the pandemic. A lot of people felt like they were just chasing all the time. And relying on public health messaging doesn't work either, because public health messaging usually comes after the fact, after something already probably have happened. Well, that's a trend that has been happening. So being prepared is the most important part. And in speaking to what Cheryl mentioned earlier about the readiness planning, this is what readiness planning is all about. It's about ensuring to make sure that the facility that you work at or your healthcare service facilities are ready, and they can answer the question that whether or not they're capable of operating in a safe way during a communicable disease event. They can say, yes, we are, by making sure that they have a readiness plan in place. You want to be able to be ready for those events where it will challenge you operationally. When there is like an influx of clients waiting at your door, or half of your staff have been called away to help in other areas, or people are vomiting, unfortunately, in your waiting room. And you want to be able to be ready and be able to evaluate your own facility and determine, can we operate with these stresses? And this is what readiness planning is all about. So if you need support with readiness planning, please contact us, let us know, and we'll be more willing to help you with that planning. And it's not about us telling you what to do. It is the collaboration and that partnership and that shared understanding. Because again, there's no cookie cutter approach. It's going to be most likely a very unique kind of strategy for each and every community in their facilities. So there's our email, ipc@fnha.ca, and for CDE planning, that is cdmgmt@fnha.ca. Please feel free to connect with us. And you have any questions here, pop it in the chat or raise a hand, and please feel free to ask. What's the next thing? It was, yes, thank you. This is an addition. The community development team. So unfortunately, I forgot his name. There was a person from community development, but he's not able to attend, so we're going to speak on his behalf. The community development team basically they support communities with there's funding and supports with health planning management. So this also in the context of this presentation, and also is that support for communicable disease emergency planning and overall health planning, public health programming, no, health planning, sorry, I got it. Health planning management, oh boy. That's the link. So health and wellness plan, thank you. Oh my goodness, it's right actually in front of me on the slide, health and wellness plan. So they are there to support each community with their health and wellness plan. Thank you. And they do also are responsible for coordinating the funding, which is under something called the Health Planning Management Fund. And during the pandemic, there's also, in terms of, I know there was a question from someone, I think it was about funding. Brendan, I think you meant ask about funding. To answer your question, yes, that's where the funding comes from. That's a cyclical funding that comes to community to help support the health and wellness planning for communities. During the pandemic, and still available, I think even right now, there's also the addition of the one-time funding that's available if you contact COVID-19 needs at fnha.ca for support with CDE planning in each of the communities. And that funding is available to either hire a person, consultant, to provide that support and creating that document. We do encourage, of course, from our team that communities do try to look within the community and maybe hire within. And again, it doesn't really require a specialization in every area and every aspect. You just need a person with time and that dedication and making sure that they understand there are specialists out there to connect with to be able to help with that planning. So that's all I have for the community development team slide there.
Thanks, Daniel. And I just wanted to mention that I can share a resource with you, Casey, to share with everybody about the one-time funding. It is available until March 2024. So applications will be accepted until March 2024. And on the thing I'm going to share in the email, it's going to have the email address where you can submit your application request or any questions about that one-time funding that's still available right now. And on that note, thank you very much for your time. And I would like to open up the space for any questions that you may have.
Thank you very much. And we had a few people join, so I'm going to ask them to try to introduce themselves and give them first choice of any questions they have. And I'm just looking at my list about who came in. Albert from Hofflick.
Because my role is the emergency program coordinator, is there any way that I can sort of talk offline and figure out a plan? Because yeah, this is relatively new. I didn't know that I would be a part of the disease part. So I would like to sit down with the health team and myself with someone to ask some more questions about this, because I don't see any of my health team on this thing. Yeah, at the moment. But it's good information though. But I would like to sit down and see what works best for our community.
That sounds great. You can definitely connect with us, and I'll pop our email address in the chat as well. And we can set up a time to have a conversation about it.
Thank you, Albert. And Nicole Napoleon put in the chat that she was having trouble with her microphone, and she introduced herself in the chat. Nicole, I don't know if you've resolved your microphone issue. Maybe not. Yep, still having issues. Okay, well, welcome. Kathy Robinson. If you're able to introduce yourself and any question of the presentation, we can circle back to if we need to. She's having trouble with her mic too. Bobby Schmerda.
You said that rap name correctly.
I guess he's occupied. We'll open it up to any questions. It's a lot of information. The presentation as well as a recording of the workshop. We'll put that in a link and we'll send it out to the First Nations Circle of Practice participants. So raise your hand or put in the chat if there's any questions. And I'm looking in the chat. Daryl's asking, Albert.
No, Casey, I know HACLP has a communicable disease plan, and just wanted to make sure Albert was aware of it.
Perfect. Okay. Any questions? And in the calendar email, there is a link to the COVID community supports along with an email if you have any questions about those community supports. That's not the Allison Lohman.
Yeah, just curious for the the funding aspect of it. Are there people at FNHA who are going to support with the applications?
There isn't any specific application form, but if you send me an email, we do have some resources that we develop that can help kind of guide how the application should look and what it should include. So just if you email me at the provincial team email address, I can share those with you.
Perfect, thank you.
Thank you for that. If there's no other hand, I'm gonna ask a question. The priority community members list. I was familiar with the vulnerable persons list. I suspect it's evolved. And I wonder if you can explain that. And I'm assuming that that's linked to the circle of care concept. And I wonder if someone can give the 30-second explanation of a circle of care and the priority community members list. It's so important for things like evacuation, I think.
It is, and it has evolved a bit. So the priority community members list and the vulnerable persons list, it's kind of the same thing morphed into one. So what we like to include are things like diagnoses, certain medications or equipment that somebody needs in order to do their day-to-day things, as well as there are specific columns for each emergency. And in those, we encourage people to write, for example, during a fire, what supports will this person need and what equipment will they need, like what's crucial. So during any emergency that happens, a quick review of that list can show during the specific emergency who needs support and what kind of supports they need. And circle of care, that's actually a great question. So that includes anybody caring for the person in a health perspective. So that's doctors, nurses, dietitians, etc. And when the list is created, we do keep in mind that there is very confidential information on there. And there's another version of it that is created that doesn't include the specific confidential pieces, more so just the support pieces. So that adapted list is the one that we would share with teams during other emergencies that are not a part of the healthcare team, but can definitely utilize it to support the priority community members. Does that answer your question?
Yeah, and I'm a big fan of both. I encourage everyone to have a look at the materials. That list and circle of care, continuity of primary care is so important for your members and the role that your community has. Rose Jack, I see your hand raised.
Yes, I came here, I was invited by Zaina. She's our health and safety manager. And I had brought up to her a couple of weeks ago about MRSA. And the fact that we always seem to have outbreak of MRSA after we come back from our annual camp out at UQuat. UQuat is on, it's isolated community. We go out there every year to go camping, probably about 200 of us. Everybody swims in the same lake, and, there's just a lot of togetherness and whatever. And I noticed that when we come back from camping, people start breaking out in boils. And when my grandson was 9 or 10, he's now 22. He told me, he said, Graham, he said, I have a red spot on my knee. And I said, okay, show me. He said, I think it's a mosquito bite. So I looked at it, and it was it looked like a mosquito bite, but it had a head on it. So I said, well, keep an eye on it, put a marker on the red area. And the next day it was bigger. So I brought him down to the clinic, and the doctors looked at it. It was hot and red. And he said it might be underneath his kneecap where the infection was. So he lanced and drained out all his pus. They did a swab, and it was MRSA. And the year before that, there was a bunch of other people that came out from UQuat, and they came out, they had boils like on their backs and on their behinds, and went to the clinic. They were treated. They didn't know what it was. And then when my grandson went in, they said it was MRSA. And every year since then, we've had numerous people coming back from UQuat with it. So I was just concerned because 2 years ago, my daughter-in-law got severely sick with we didn't know what it was, but she was really sick. She ended up in the hospital, just about lost her life, and turned out that she had my emergency alert just went off on my phone. Turned out she had MRSA that she had picked up from some other youth that had been out at UQuat, and they never treated it. So she got really sick. She's still recovering yet. It's been almost a year and a half. And it just spreads, like, very contagious. They give you antibiotics or whatever, but the latest they told me the treatment is bathing in bleach, half a cup of bleach to your bath water every day for 4 months. They said that's the only way to get rid of it. So when I brought it up to Zaina, she said, maybe we need to bring it up and have a discussion about it, and maybe do a study out at UQuat or whatever, and see if there's something in the water, or like, where is it coming from? And for every year to come back from UQuat and have people end up with MRSA gets quite concerning. So I thought I'd bring it up and see if there was, anything that could be done.
Thank you, Rose. If I understand it correctly, in the emergency management list that we just put out about a week ago, I think there's an FNHA program, but I could be mixing it up, on environmental contaminants, or am I mixing that program up? Is there any avenues for the band to kind of explore if there's something in the water?
I think a good contact would be the Environmental Public Health Services, EPHS. Is a good contact. I'm trying to think of what their email is.
I think someone from there contacted me, but Zaina just thought it would be good to bring it up here to see if there was anything that could come out of this meeting. But I will contact the guy that phoned me. He's phoned me twice, but both times haven't been able to speak to him. So I'll reach out to him again. I can't remember his name offhand. It's in my emails.
Thank you for sharing, Rose.
Any further questions on the information materials provided? And it's okay if there isn't. In the chat, I put the relevance of so many of the plans that First Nations do, the health and wellness plans, the CCPs, land use plans, emergency plans, wildfire plans, your infrastructure investment plans. In emergency management, if you look at the 9 principles of BSEM, the BC Emergency Management System, you know, BSEM number 4 is protecting public health, and it's you know, the health and wellness of your communities before, during, and after disasters and major emergencies. Hugely important. And the role of your health teams in the safety and well-being of your communities. I have a ton of respect for the work that they do. I see a question in the chat. Nicole, what do we do with all the PPE that we currently have that may be due to expire? Does FNHA take them back, or do we discard?
There are some options. One option is you can potentially use it for training purposes. Training is always great to have, and sometimes PPE is not cheap. It is very, 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 very expensive, especially the gowns. Like several boxes of gowns, you can run up to several grand already in the dollar figures. So but you have to make sure that those ones that are about to expire is set apart from the mainstream, from the rest of the inventory. But if you have room and have space, training is good to use them for. And if you need help with training, basically running virtual training programs or others in community, let us know, and we can definitely help your healthcare staff with that training. And therefore that supplies can be then used up. So that's one avenue. Another one is even though some PPE, as we know during the pandemic, there was PPE that was about to expire or already has, you know, passed like several days past the expiration, but the provincial government, of course, gave the AOK to continue using the PPE when properly inspected for the inventory. Of course, during the pandemic when PPE inventory was so low, there, you know, it's you might want to keep it for a little bit longer, right? But again, if you don't have space and you don't have any training lined up or just have way too much for even training, then it's unfortunate that this is the burden on the ecosystem and the landfill when we do have to throw them out.
Thank you, Daniel. Any further questions? And I encourage everyone to read the COVID Community Support Guide. It's in the calendar invite, and there's an email for any questions, including if you read the guide and there's funding and supports to do the CDE plan. Back when I was an emergency coordinator during COVID, when they were called pandemic plans, I remember the funding that was put out each year to develop the pandemic plans. So I encourage people to read that and direct any questions to the email in that guide. And if there's no questions, my thanks to the presenters for putting this on relatively short notice. Super appreciated. My thanks to all of you who've taken the time to be here today. We will create a link for this workshop, and if any materials or presentations can be sent to me, I'll make sure that they're circulated as well. And I'll make sure that FNHA gets a copy of the link as well if they want to share it. And if you can keep us in mind for those webinars, I think it's great to promote some alignment and some collaboration between the emergency coordinators and the health teams for these webinars and TTX and stuff. So anything you share that you'd like to go out to the circle of practice participants, I'll make sure that they get on those upcoming webinars. So my thanks to you all, and have an awesome day, everyone.